Yeah, go ahead. What is your topic?
So my topic for today is role of anesthesiologist in artificial assisted reproductive technologies. Sir. So, sir, ART or artificial reproductive technology is a primarily used primarily to address the treatment of infertility, which includes techniques associated directly associated direct manipulation of oocyte or sperm outside the body. So generally nowadays it is practiced as a daycare procedure, and thus many anesthetic regimes have been used like general anesthesia, regional anesthesia like central neuraxial blockade of including spinal and epidural, peripheral nerve blocks like paracervical block and ovarian block, conscious sedation, monitored anesthesia care, patient controlled analgesia, acupuncture, and TENS. Indication for assisted reproductive technology are, sir, female factor contributing 40%, male factor contributing 40%, and combined or unexplained factors that are 20%. In female factors, we should consider for adequate oocyte quality and number, tubal factors, endometriosis, anti-sperm antibody, irreparative or absence of uterus. While in male, sperm deficiency, that is decreased sperm count or decreased sperm mobility is considered. Ejaculatory factors, obstructive or non-obstructive azoospermia, retrograde ejaculation is seen. While for combined or unexplained factors, unexplained genetic aberration in couples are seen. So procedure involved in artificial reproductive technologies are hormonal stimulation, followed by oocyte retrieval, followed by in vitro fertilization, followed by embryo transfer, gamete intrafallopian transfer, zygote intrafallopian transfer, surrogacy in case of uterine abnormalities in the female, like egg donor technique or gestational surrogacy. For male, intracytoplasmic sperm injection if mobility is decreased, or testicular sperm extraction TEAC. So, or testis biopsy is also done in some cases. So prior to initiation of assisted reproductive technology, we should evaluate like ovarian reserve in the female, semen analysis, infectious disease like HIV, HBV, HCV, and tuberculosis. Mock embryo transfer should be tested once. And uterine and tubal evaluation by hysterosalpingography, hysteroscopy, or sonohysterography to be done. Steps which are requiring anesthesia for IVF are oocyte retrieval, which is one of the most painful procedure and most important step in vitro fertilization. Testicular biopsy. Third is to treat the artificial reproductive complication like OHSS or post-procedural complication during embryo transfer like GIFT or GIFT or embryo transfer. And in case of delivering of baby, because most of these pregnancies are associated with multiple gestations. Ideal anesthetic method, as such, no general consensus is there regarding a best or least harmful anesthetic technique, but ideal anesthesia is that which provides safe and effective analgesia and adequate analgesia with rapid onset and recovery with minimum side effect and no effect on the oocyte or the sperm. Third, there should be no change in the follicular pH or fluid due to the drug which we are administering. It should not affect the fertilization, early embryo development, and pregnancy. So generally, the patients which come for artificial reproductive technology are young and healthy, and and therefore they may not require any lab studies if they are clinically fine. Or investigations like ECG or chest X-ray, we can directly proceed with the surgeries. But consideration should be taken in account for drug interaction, because during hormonal stimulation we are giving GnRH agonist or antagonist. Due to that, hormonal manipulation will be there, and there will be change in the level of albumin or alpha-1 glycoprotein. Therefore, increase in the free fraction of highly protein bound drug will be there. So dose reduction should be taken in account. Coexisting disease in these patients might contain like PID or thyroid disorder. Pregnancy itself is a hypercoagulable state, thus, and it is further aggravated by gonadotropin injections. So, furthermore, patient may be on anticoagulant drugs like aspirin or heparin. Therefore, these drugs should be withheld accordingly, which the patient is taking. Some patient may suffer from anxiety, depression, or psychosis due to societal or family pressure. Therefore, the patient may be on SSRI, which causes P450 inhibition, which has a synergistic effect with anticoagulant, therefore increasing the risk of bleeding. NSAID should be avoided in these patients for analgesia. Fertility
Which drug specifically, Pratik? Which drug specifically in these regions? Patients are necessary.
Ma'am, antico means they are on high risk for bleeding, ma'am. So non-steroidal anti-inflammatory drug should be avoided so as to prevent.
More than bleeding, what is the interaction with the
Sir, drug interaction with SSRI means heparin will be having means interaction with SSRI, sir. Opioids also, ma'am. Opioids also, ma'am. Opioids also.
Yeah, we are concerned about that because invariably we will be using small amount of opioids, isn't it, for analgesia. So if the patient is on SSRIs, we have to be very careful about titrating the doses of narcotics.
Okay.
So that becomes very important. And in the beginning, you said you have they're young patients. They have no, they're not. It is quite the opposite now when you see these patients. They're older patients. They have all kinds of problems. So it is not at all sufficient for us to take away this patient as ASA 1 or 2. They come with ASA 3 and above. So it's really difficult. And taking them as a daycare procedure for us is really challenging. Because and the use of spinal, earlier you said in the beginning itself, you said something about use of spinal and regional block for ovum retrieval, which as a daycare procedure, though earlier it was not recommended, now with the use of 27 needle and other things, it is accepted. But still, if you want to do any patient as a daycare, it is preferably done under general anesthesia. So you just need to keep that in mind. So these are the few things which I followed what you said in the beginning. I'm saying it in between because I'll tend to forget afterwards. So that's why I'm telling you straight away. Okay, all right.
Thank you.
It's another major challenge. Majority of these infertile women are, as you said, a thyroid problem. The obesity may be hypothyroidism induced, or their genetic nature itself, they may be seriously obese. So therefore, obesity problems of OSA, joint problems, all these things also they may be having. Okay?
So I'm coming up to
The other
that.
way also be there.
Yes, sir. So some patient comes for fertility preservation, like patient on chemotherapy and radiotherapy for basic malignancy. So responses so their responses for ovulation is decreased, and risk for organ dysfunction is quite high in those patients. And most of the females are obese, which come in this. So consideration for liver and renal dysfunction might be considered, and along with that, difficult airway should be kept in the mind, sir. Now going for anesthetic management during all these procedures. After considering NPO, informed written consent of the patient, having adequate monitors and IV access, then we'll go for the procedure like oocyte retrieval. Nowadays, transvaginal oocyte retrieval is done under daycare as a daycare procedure, and anesthetic technique which can be employed here are general anesthesia, which is done most commonly so as to relax the uterus, leading for early aspiration of the fluid and follicle. Since there is no movement and relaxed uterine wall, surgeons and patient do prefer this approach. So drugs which will be using in under general anesthesia in these cases will be propofol, which is the first choice of drug, since it has no detrimental effect on fertilization and early embryo development, despite it gets accumulated in the follicle. Thiopentone, it also has no reproductive side effects, but when compared to propofol, there is increased recovery time in case of thiopentone. Ketamine shows a decrease in fertilization. Therefore, ketamine is used with combination with propofol or midazolam. Etomidate, it is not preferred because it causes suppression of the gonadal hormone, so we should avoid using etomidate. So opioids are used as component of balanced anesthesia. Synthetic opioids like fentanyl, remifentanil, alfentanil are safe and are not associated with any effect on pregnancy rate or embryo development. But morphine is seen to cause polyspermia in a single oocyte. Therefore, it is not preferred. Benzodiazepine, most commonly used benzodiazepine is midazolam, and it is not associated with any teratogenicity or rate of pregnancy. Inhalational agents are nitrous oxide. It causes decrease in methionine synthase activity and decreased DNA synthesis activity. Therefore, it hampers the mitotic spindle formation in the cell. Thus, TY is much more preferred instead of using any means nitrous oxide. In fact, volatile halogenated agent also it is avoided because it causes depression in the DNA synthesis and mitosis in the cell structure. Therefore, oocyte maturation is decreased. Isoflurane is known to cause adverse embryogenic development. And compound A of sevoflurane is also associated with genotypic ovarian cell defects. Therefore, it is avoided. So, general anesthesia is considered along with spontaneous or assisted mass ventilation with total intravenous intravenous anesthesia with propofol as a preferred drug along with midazolam or fentanyl. If
Actually,
aspiration
ketofol, yeah, the
yes, ma'am,
combination drug. Yeah, ketofol is the most commonly used combination nowadays
yes,
for most of the procedures. We don't use any inhalation agent. So if you give adequate ketofol and just hold the mask with oxygen air, it is sufficient. And did you say something about bromocriptine? There's always something which people talk about bromocriptine, is it?
Ma'am, I will say that in antiemetic part. I've
Okay,
written.
okay. All right. Okay.
Uh, so if aspiration risk is there, suspected, then we should put a cuffed endotracheal tube. And if at all we are suspicious that patient might go into aspiration, as it is an elective case, we can postpone the case and again we can take up later on. So now antiemetic drugs like ondansetron is preferred. Metoclopramide, droperidol, it increases, and bromocriptine, it increases the prolactin level, therefore impairs the ovarian maturation and corpus luteum function. Thus, these drugs are avoided and only ondansetron is preferred. Regional anesthesia in form of central neuraxial block or peripheral nerve blocks can be used like subarachnoid block along with low dose opioid. Mevivican along with fentanyl or bupivacaine with fentanyl is preferred if at all we are going for subarachnoid blockade. Epidural is less preferred because sir, increased level of toxicity dose of local anesthesia is seen and it may hamper with the oocyte. It may get accumulated in the follicular fluid and hamper the further maturation of oocyte.
Yeah,
Paracervical.
we may take longer time to do the epidural than they will take to do the USI. So it's better not to venture to do epidural.
Yes, a second peripheral nerve block technique is paracervical nerve block. Local anesthesia is injected at 2 to 6 sites at around 3 to 7 mm along with the vaginal fornices, but it does not cover the pain fiber of the ovarian wall. Therefore, it should be supplemented with sedation if at all when used. Other block is pre-ovarian block. It is a newer technique. Local anesthesia is injected in the vaginal area between the wall and the peritoneal surface near the ovary under vaginal ultrasound guidance. Conscious sedation and monitored anesthesia care. It is the second most widely accepted technique after general anesthesia for transvaginal oocyte retrieval. It uses drugs like propofol, fentanyl, midazolam, remifentanil, and dexmedetomidine. Other technique which can be used for oocyte retrieval is patient control analgesia with fentanyl, which enhances the patient comfort and satisfaction. Other drugs which can be used in PCA are remifentanil, pethidine with midazolam. Acupuncture and TENS. It is never done alone. It is always done along with some advent like conscious sedation or blocks or with GA. It increases beta endorphins and has sympathoinhibitory effect and antidepressant effects. Best advantage of acupuncture in TENS is that it is non-toxic, it has no effect on fertilization and pregnancy. Anesthetic techniques during embryo transfer. Embryo transfer is generally painless when done via transcervical route.
One
Therefore,
minute, before going to ET, before going to the embryo transfer,
yes, ma'am.
why you're not talking anything about Dexmed?
Dexmed, ma'am,
It's
it is
routinely used nowadays. Yeah, with ketofol, with ketamine propofol, if it is not sufficient for this transvaginal oocyte retrieval, when they use the ultrasound, sometimes they are fat and they don't, you can't see it very well, isn't it? So that time, what will happen is the patient, what is the first basic requirement for this oocyte retrieval?
ma'am, patient should be stable, means that because it is a very painful procedure, patient might move due to pain if at all adequate analgesia is not.
Yes, excellent analgesia is required. Very good. Next.
So Dexmed is a very good drug for conscious sedation. Patient.
No. Don't go to Dexmed. Requirement.
Sorry, ma'am.
You said very good analgesia. Yes, very good. Then what else?
And
The
ma'am,
respiratory movement. The respiratory
it should be.
movements while they're doing the retrieval should be
It should
minimal.
not be there. It should
Right?
not be there.
Yeah, because if they move too much and the abdomen is moving too much, they will not be able to pick the oocytes. So the respiratory movement must be very smooth and very, the rate must not be very high and they should not be bucking and all that. So for that, to make it very smooth, Dexmed is a very useful drug. It just gives you excellent analgesia, at the same time gives you a good sedation and kind of brings down the heart rate and everything comes down in combination along with ketofol. So it is a very good drug. So don't miss out on use of Dexmed.
Okay, ma'am.
Of course, you said something. You said something about nitrous oxide not being used, and you said about the inhalation agents. All that is accepted. So the thing is, the requirement for this, though they say it is a short procedure and it is just ovum retrieval, the requirement from the side of the anesthetist is quite taxing, especially when they have associated medical issues and obesity and hypothyroidism and things like that. And logistically, even to position these patients for lithotomy position, because it is not done in a nice regular theater with all the theater setup. It is not like that. Invariably, it will be done in small places. The table will be the second hand or third hand table. It will really not be nice. So these are the things which you need to look in before you start anesthesia anywhere. So don't compromise on the safety of the patients. 90% of the time, sometimes even we don't even have a proper anesthesia machine. So insist on having a proper anesthesia machine, oxygen source, intubation kit, everything should be there. Like a proper general anesthesia. We should never compromise on that. So that is something which all the postgraduates need to know, because they've had catastrophes by doing cases like this as out daycare. Okay. So don't even dream of doing that. Do it correctly. Whatever you have to do it. Safety is the most important thing. Okay. Yeah. Don't forget Dexmed. Dexmed is an excellent drug. Okay.
Yes.
Paracervical block. You said something about paracervical block. Yes, it is very useful, but that alone is not sufficient. I think you said that also. All right. Okay. So have you finished everything? Oh, wait 1 minute. Let me check whether you finished everything on before you go to ovum retrieval. I mean, before you go to
Embryo transfer.
embryo transfer. Yeah. And then you said about the protein. What did you say? Something about the protein. You said something about alpha glycoprotein and albumin. What is that? What you're trying to say?
Ma'am, because patient is on hormonal manipulation due to GnRH agonist or antagonist, there is a hormonal manipulation which causes change in the level of albumin and alpha-1 glycoprotein. Therefore, ma'am, normally means it causes increase in the free fraction of the highly protein-bound drug. So dose reduction of the drug.
Albumin bound drug. Which drug is albumin bound?
Acidic drugs like acidic drugs में जो भी आ जाएंगे.
What drugs that we use in practice is albumin bound, and we need to be careful.
Thiopentone.
It was highly alkaline.
Acidic कौन सा होगा?
What about fentanyl? What about propofol?
Propofol तो.
So when you set a point like that, you set a point that about protein binding. So immediately you must look up what are the drugs which are bound to albumin, and which are the drugs which are going to be free fraction without that. Okay.
Yes, ma'am.
So what are the drugs? Any idea? Anybody else? Acidic drugs. He said correctly. He said acidic drugs. What are the drugs? Anesthesia drugs only. I'm not asking anything else. Okay, you look up and text me.
Yes, ma'am.
Okay, all right. Yeah, continue. And there's something about tetracaine, no? I read somewhere about tetracaine, use of tetracaine.
I
Is
mean,
it something very? Did you read about it?
in blocks, they are using tetracaine along with paracervical blocks and pre-ovarian blocks. They are using tetracaine, I think.
Yeah. Why is it different from using the lignocaine?
Sorry, ma'am.
You read, no? You read somewhere that they're using tetracaine, right?
I read, ma'am. I just forgot it.
Yeah. So would you not check to see why tetracaine? Okay, there's another homework for you. All right. Okay, continue. We will go to ET.
Yes, ma'am. So embryo transfer, generally it is a painless procedure when done via transcervical route, but it may require occasional sedation. If GIFT, gamete intrafallopian transfer or zygote intrafallopian transfer is done, it is done via laparoscopy. So GA or neuraxial blockade will be mandatory. For GIFT, anesthesia depends on the approach taken by the surgeon, whether it is done transabdominally or transvaginally. If transabdominal approach is used for oocyte retrieval, then patient can be positioned and anesthetized for once for both retrieval and transfer of the gametes in a single setting. The disadvantages of GIFT includes that gamete is exposed to carbon dioxide, therefore it causes acidification of the follicles and leading to decrease in the rate of fertilization. While zygote intrafallopian transfer, oocyte is retrieved if transvaginally, then in the second setting or second procedure will be done next day and zygote will be implanted in the fallopian tube. So advantages of zygote intrafallopian transfer is documentation of the fertilization is done, avoidance of laparoscopy if no fertilization, which can be visualized under microscope, or pronuclear stage can be seen under microscope. Third, there is no exposure to the to carbon dioxide to the gametes or oocyte. The only disadvantage of GIFT is laparoscopy is needed and it is a two-step procedure, thus increases the cost of the procedure. Third procedure which we are doing is testicular sperm extractions. It is generally done under local anesthesia. It might require sedation if at all required. Post-op management, post-operative or post-procedural management. Uh, Generally, patient is discharged on the same day. Most common indication for hospitalization after procedure is surgical complication like hemoperitoneum, unexplained syncope, bowel injury, abdominal pain, nausea and vomiting, incisional pain, or shoulder pain. To manage all these cases, heating pad can be used or intravenous fentanyl 25 to 50 micrograms is given. NSAID is avoided as it causes prostaglandin level changes and it affects the embryo implant post-operatively also. Nausea and vomiting should be controlled by IV ondansetron. So now last point is success of the assisted reproductive technology. It depends mainly on the maternal age, which is the dominant factor. Second factor is if there is a previous live birth, then that is a better prognostic factor. And third is ovarian reserve. So all this should be discussed with the patient and consent should be taken prior to the initiation of this.
Yeah. Can you say something about ovarian hyperstimulation syndrome? Something more
Okay,
about
ma'am.
it. Suppose
And I
they ask
think
you short
repeatedly
notes.
asked as a short note question.
Okay, ma'am.
Hmm.
Ma'am, it is a complication arising due to extra means since we are stimulating the ovaries along with gonadal hormones, therefore ovaries can get extra stimulated and it may lead to ovarian hyperstimulation syndrome. And in this, patient may land up into means It can be divided into two subheads, mild and severe. In mild cases, ma'am, abdominal discomfort will be there, bilateral ovarian enlargement will be there, ascites will be there. While in severe cases, it may lead to hemorrhage, pleural effusion, massive ascites, uh, oliguria, thromboembolic phenomenon might be there. So we'll have to manage accordingly, according to the stages. Patient will be managed, and if patient is landing up into OHSS, the oocyte retrieval time can be early. Man, we can extract the oocyte earlier, and we can let that oocyte mature in the media or culture media if that is immature, and then we will go for the embryo transfer or GIFT or GFT, ZIFT.
What's the pathophysiology?
Ma'am, we are giving hormonal stimulation, extra hormonal stimulation in form of GnRH agonist like buserelin. So because of that extra stimulation, ovaries get stimulated, means not normally over the
Produces
normal. So
vasoactive substances. Okay, it produces
okay.
vasoactive substances like interleukins, and just like any other inflammatory thing. Okay, interleukins, tumor necrosis factor, and endothelin 1. These are the things. These have been implicated for the increase in vascular permeability, and from then on, all this happens. Okay, and the classification is again divided as mild, moderate, and severe. And in the mild, you have grade 1 and 2. And the moderate is grade 3, and severe is grade 4 and 5. Okay, so that's how much they have divided it now. It's not just mild and severe. Okay, they divided it into 5 grades. Mild is grade 1 and 2, moderate
Yes,
is grade 3, and severe
severe
is 4
4
and
and
5.
5.
So these things up to acute renal failure. The thing has
Okay,
gone up to acute renal failure because it goes on to the renal perfusion also. Okay, and then of course treatment depends upon the stage in which
So,
you are looking at it.
yes, ma'am.
Sometimes it's very difficult. Will be so. I have seen one case. I've seen one patient in the post-op, actually post after the procedure. In fact, they're supposed to, if they comes before, they're supposed to remove the ovum retrieval before, isn't it? That's what you
Yes,
said.
ma'am.
If
Yes, ma'am.
they do the ovum retrieval
Early.
and then you put the embryo transfer later, which is started developing dyspnea. So we didn't even know there's a embolism, and then of course with the empirical treatment she was okay. So that can happen anytime. So you have to be very careful about it.
Yes, ma'am.
Nicely presented. Vasanthi, should we include the follow-up in these patients and their final delivery also?
Sir?
Should we include the follow-up of these patients after embryo transfer up to the stage of final delivery? Because
yes, sir, I have done, sir. Yes, sir. Up to cesarean section, sir.
yeah,
So many patients have come and asked.
Sometimes they go for multiple pregnancy, multiple fetuses also.
Yeah, multiple, sir. Always it's multiple pregnancy. Twins, usually twins, and up to
30%.
cesarean section, sir. Yeah.
So that's why
So it's starting from the, yeah.
Yeah.
Sometimes it's very satisfying, sir. They kind of remember you throughout.
Yeah.
So it's very nice, sir. Yeah.
Thank you. Nice presentation, Pratik. You did a good job.
Yeah,
Thank you, sir.
Pratik, very good. Very good.